In California, our elected officials took action very quickly, shortly after enactment 2 years ago, putting into place many of the essential statutory building blocks upon which implementation of federal reform will play out and be built at the state level. Now, the federal reform provides a very clear framework, but at the end of the day, it really is state decision, state policy and practice that's going to determine whether or not the promise of the Affordable Care Act in terms of expanded coverage and access, improved affordability, greater quality, and better health equity becomes a reality for California residents, for our communities, and families broadly. Effective state implementation of the Affordable Care Act is going to require really an unprecedented collaboration among policymakers, health plans, insurers, providers, consumers, businesses, and many, many others. Policymakers, researchers, and health funders have particularly important roles to play. Our state policymakers face numerous complex, consequential decisions and implementation tasks that are going to have to be made under enormously ambitious timelines and in a very challenging fiscal, political, and legal context. Our state researchers can assist policymakers in terms of their efforts to evaluate those decisions and trade-offs, to implement programs, and to evaluate the allocation of resources by producing an array of policy, operational, and empirical research. Our health foundations can contribute both their intellectual capacity as well as financial investments by supporting the generation of new knowledge and by helping to move that knowledge into policy and practice. How well these key players collaborate is going to have a significant bearing on how successful reform is in California. PPIC's briefing today is intended to examine the role of research and information and analysis in helping California get ready for reform and strengthening implementation in our state. This is a topic of interest to PPIC. We undertook a project this past summer with the support of the Blue Shield of California Foundation. Thank you, Peter. That really looked at and examined the ACA implementation research landscape, identified policy research needs and priorities, and explored how to promote a more coordinated research agenda around the Affordable Care Act. Today, we're fortunate to have leadership from all three of these communities, funders, researchers, and policymakers. We're going to begin with Peter Long, President and CEO of the Blue Shield of California Foundation, who's going to make some opening comments. We're then going to hear from PPIC Research Fellow Helen Lee, who will provide an overview of the project our Research Institute undertook this past summer. And then we're going to turn to a panel of leaders who are representing the key leadership that really is so critical to implementation. Diana Dooley, Secretary of Health and Human Services Agency, which oversees a number of the critical agencies with significant new and expanded responsibilities under the Affordable Care Act, including the Department of Healthcare Services, the Department of Managed Healthcare, and the Managers Medical Insurance Board. And Secretary Dooley also chairs the Health Benefit Exchange, which is playing a key role in implementation of reform. Andy Beinman, raise your hand, Andy, professor from UCSF, who's also a primary care physician, a health services researcher, and the founder and director of the California Medicaid Research Institute, which you're going to likely hear more about in just a moment. And finally, Marian Mulkey, who's the director of the California Healthcare Foundation's Health Reform and Public Programs Initiative. Raise your hand, Marian. Thank you very much. So let me begin with Peter Long, who I said is President and CEO of the Blue Shield of California Foundation, which is a foundation committed to improving access to care for all Californians, particularly the underserved, through more accessible, affordable, and effective healthcare. Peter brings not only an institutional commitment to research and evidence to inform and transform policymaking and service delivery, he also brings a personal commitment because he has those initials after his name of PhD in health services. So please join me in welcoming Peter Long.
Thanks very much. It's great to see such a good crowd here. Thank you, Kim and Helen, for your work and the research that we're going to hear about, but also for organizing the briefing. And thanks to our panelists. I couldn't think of three people who can share this perspective between research, policy, and funding, and kind of how that fits together than the three people we're going to hear from in a minute. So I think you're in for a treat in terms of, A, this is excellent research that's top-notch. As you can imagine, Kim, anything that Kim puts her mind to is thorough and top-notch. And what she's walked us through, and you're going to hear, is not just what the landscape is. Because if we think about health reform is not a snapshot. And as I always like to say, it's not self-implementing. It really is a homemade movie that we're all co-creating together. And so it's wonderful to have a landscape of what research looks like and what funders are doing. But Kim and Helen have gone further into take us to say, well, what are the gaps between what we need to know and what we do know today and we're going to know? And then how can we do a better job to fill those gaps and to make sure that we have the right information to make the decision going forward? So I think it's going to be a great conversation that lays out interesting findings with some very, very relevant perspectives. Blue Shield of California is committed to ensuring access to health care for all Californians. We think that's a dynamic process in this environment. It's happening and changing every day. And we think research and information are a critical piece of that. At the foundation, we like to think of research plus relationships equal impact. So as you're thinking about this conversation today about what the information needs are and whether it be in workforce, access to care, who the remaining uninsured will be, prevention, think about your relationships, think about the decisions that you're making, think about your institutions and how you put that information to work. Because I think information is only as good as what we do with it. Because ultimately, this is about changing the healthcare delivery system to provide better access to folks on the ground. And so the research is a critical and important input, but it's about what you do in your organizations, with your relationships, with your decision-making authority, your influence to make that, turn that into reality on the ground. So as you're listening to the kind of information and the inputs and you're hearing the reactions from our panel, I really want you to think about how you will be putting this information to work. Because really this briefing is about policymakers, but it's also about you and each of your organizations and how you are moving forward with health reform. I'd love to say, and I think I'm a health services researcher by training, and I'll confess it took me 8 years to get my degree, so I don't do anything fast. It would be wonderful. I have 3 young kids, for those of you who know me, and I watched the Muppet movie over the weekend. And it would be wonderful if we could say, let's do the rest of the research in a montage scene, where we, in 3 minutes in the film, we take care of all these issues, get Diana and the team every bit of information they need. It all works out perfectly, and Miss Piggy shows up and sings the dramatic conclusion. Unfortunately, our life is not the Muppet movie. I'm a man and not a Muppet. But so it would be wonderful. But one of the things that Marion and I were talking about, I think it's why it's so important that we have both researchers and funders here, is there is a long lead time. And you'll see, and you're going to hear in a second, we've done a superlative job on the things we've been thinking about for the last 10 years. What we need help on are those incredibly complex, dynamic things that come up once we get the first set of analysis. So we need to think about in real time how we're staging it as funders, how researchers are being as efficient as possible, and how policymakers are using it and guiding that process going forward. So with that, I'm going to turn it over to Helen to hear the findings. I think this couldn't come at a better time, not just the 2-year anniversary in the Supreme Court, but this really is the time that we've gotten phase 1 of health reform done. And now we're at probably in Kim's time, we're at noon on the day before health reform. So we've now got 12 hours, 2014 is tomorrow. But it's a great opportunity to reflect about how we're going to get the information we need to make the decisions that are going to be critical to be, to have successful implementation of health reform. So with that, I will turn it to Helen and look forward to the conversation. Thank you.
Well, thanks, Peter, for the introduction, and thank you, Kim. Before I begin with presenting the overview today, I would like to acknowledge that this really represents a collective effort at PPIC. Kim Belcher's leadership, Shannon McConville is a policy associate at PPIC who worked very hard on this project, and also the support of the Blue Shield of California Foundation, and especially Richard's guidance. Richard Thomason's guidance. So for some of you, this background slide is something you've been living and breathing for the last 2 years. But for others who are less familiar, we thought we'd briefly outline some of the key elements of what federal healthcare reform, or the Affordable Care Act, the ACA, is supposed to do, and the critical importance of program design and implementation decision-making at the state level. So the primary goal of the ACA is to greatly expand access to insurance coverage to low and middle income uninsured Americans. It will do so by expanding the Medicaid program, Medi-Cal in California, which is expected in come 2014 to see an increase of about 2 million more beneficiaries. It will also do so by creating the Health Benefit Exchange, a new marketplace that offers affordable coverage to those who currently cannot afford coverage or not offered employer-sponsored coverage. And finally, there's a requirement that most U.S. citizens and legal residents have some form of health insurance. This is known as the individual mandate. Many of these provisions will become effective as of January 2014. And despite ongoing political debates over various provisions of the new law, and we're hearing oral arguments today in the Supreme Court level, California is already preparing for some of the major changes that the ACA requires states to undertake as part of healthcare reform. For example, it was the first state in the nation to create a state-run health benefit exchange governing board, and it also used the opportunity of its renewal of the federal Medicaid waiver to expand low-income health programs as an effort to gear up for the Medicaid expansions under reform. So about a year ago, to give you some context to our study, we at PPIC were having internal conversations and external conversations about the research landscape surrounding the ACA, research that could be used to inform the state's efforts to implement the ACA in an evidence-based manner. And one thing became pretty clear from these conversations was that we didn't have a good sense of who was doing what, or how much overlap there was, or how policymakers were gathering the research information that they needed to make their decisions. And so over the summer and fall of 2011, we at PPIC began an endeavor, which was to capture research that is underway or completed that could be used to inform state implementation decisions. We also wanted to learn more about from this broader health policy community, including funders and researchers and policymakers, about what are the key top-line research priorities. And finally, we wanted to hear their thoughts on how to advance a more coordinated ACA research agenda. Now, we undertook this task with the acknowledgement that we could at best provide a snapshot that would be outdated by the time we did it, because research is ever evolving and shifting. And research, it should be noted, we're defining it very broadly. So it can include very applied policy analysis, so research that asks, what's the impact of this lever? It also includes operational research, so how to best practices, how to best implement this program, to more scholarly work where the researchers are concerned about what's my original contribution to the field here. And to address these objectives, we identified and interviewed leading health policy researchers across the state, selected by their track record of scholarly work and by their policy influence. We also strategically chose researchers who specialize in different aspects of health policy, which is very broad, in order to capture some depth and breadth of research. We also interviewed program leaders from the state's major health foundations, including Blue Shield of California Foundation, California Healthcare Foundation, the California Endowment, and California Wellness. And finally, we solicited input from state policymakers, particularly leadership at the Health and Human Services Agency. So altogether, we conducted about 36 interviews. And based on these interviews, particularly with researchers and program officers, and also supplemented with targeted literature scans and website searches, we created basically what we're calling an inventory of research that is underway or completed. As you can imagine, it gets bigger by the minute, and it's about 100 pages now. But it is a useful resource, we think, and it's categorized into different topical areas like accountable care organizations or risk adjustment or the newly covered populations. It's available at our website, and because we do think it's a valuable resource, we hope to keep it updated and also make it a little bit more user-friendly in the future. So through our discussion, we sat back and looked at our notes from our interviews, and we basically identified 6 different research priority areas that were commonly underscored by our respondents. And each of these areas really mirrors the larger goals of the ACA, as you can see. For example, one priority area is research that could help inform the state's efforts to ensure access to affordable care for the newly covered populations, including Medi-Cal and the exchange. Researchers also noted the need to improve information on workforce capacity and healthcare service delivery in recognition of the increased demands on healthcare providers that will accompany these major expansions in coverage. There was also recognition that the state needs to continue to play its important role in supporting the safety net for the millions who are projected to remain uninsured or outside the scope of coverage in a post-ACA world. As many of you know, market-driven system change has been reinforced by the ACA, which provides new tools and resources to advance innovation in healthcare provision. For example, there's increased federal funding to support state efforts to create medical health homes for Medicaid beneficiaries with chronic conditions. There's also support for the increasing use of accountable care organizations in Medicare to improve cost efficiency and quality. Respondents noted that these innovations need to be tracked and evaluated and monitored. And in line with market-driven system change, the ACA establishes new insurance rules and market constructs and regulatory requirements to help achieve its goals. And our experts noted the importance of research that could identify tools to assess impacts of these changes and also identify unintended consequences. And finally, the ACA represents a vision of health improvement that recognizes the role of access to healthcare services in improving population health, but also recognizes the role of community prevention in promoting and optimizing health outcomes. And researchers also identified the need to assess what those new tools and resources are so we could more effectively promote prevention in the state. And under each of these broader topical priority areas, our respondents were sometimes pretty explicit about what was needed, and they were also explicit about what could be done. So for instance, several noted the need for better and more detailed information on the health needs and socio-demographic profiles and distributions of the newly covered to help with questions regarding benefit design, affordability, continuity of coverage issues, retention, and costs. And here is an area where we believe researchers do have tools at hand. These are called microsimulation models, and they're statistical techniques that project take-up and participation based on what we know from the literature about individual decision-making and employer behaviors. And health foundations like Blue Shield of California Foundation and the California Endowment have seen the need for this and have stepped in and helped support some of this work. So as a result, we have actually several different models that are California specific. And so now the challenge is in interpreting and reconciling these different estimates that these models produce for policymakers. Under the critical topic of workforce capacity and healthcare service delivery and distribution, policymakers noted the need for a model that could factor in various inputs, workforce inputs and strategies in order to model when they change those inputs, what would be the workforce yield, what would be the output. When we talked to researchers and bounced this idea around, we heard from them about the challenge of building such a workforce input-output model and data availability and limitations. And so this is an example of sometimes the disconnect between what a researcher can do and a policymaker really needs. But in the absence of such a model, we also feel that researchers can take other strategies to inform these decision-making processes because they're going to happen anyways. So tools like synthesizing existing research on the various levers, drawing from less complex models that don't do everything but analyze one factor is a good way to start. And finally, in light of limited state resources and complex responsibilities and very tight deadlines, our SCAN informants underscore the value in finding ways to facilitate connections between the producers of research and the end users, policymakers, in short, to advance a more coordinated agenda. This is not an easy endeavor by any means, but the state already has some very promising collaborative models to draw from, including the California Medicaid Research Institute, or CAMRI, and we'll hear more about that from Dr. Byman, and also the Blue Shield and UCSF Safety Net Collaborative. But these collaborative models are topically focused by design. There is not a broader ACA umbrella implementation collaborative. And there are challenges to building such a collaborative model. For example, the timing of research and policy informational need does not always align. Incentives don't always align. Researchers need funding and they want publications, and that doesn't always happen very quickly. And then there are philosophical and practical questions about where does the ultimate authority reside? Is it with the researcher or is it with the policymaker? Who has final ownership? So in the absence of a larger umbrella organization or collaborative, there are other strategies that can be taken to foster better connections. For example, one example that came up frequently in our conversations was a web-based model or portal of sorts where a policymaker or a stakeholder could pose a question to the online community, and then researchers and funders could help corral resources to answer that question. Communication can also be encouraged and fostered through a series of dialogues that are perhaps more intimate, but that are focused and revolve around a current ACA-related topic or debate. So with that, many respondents noted that the stakes are really high, and 2014 is coming very soon. And we're all eagerly tracking the fate of some of the law's key provisions. With that said, again, California has really moved forward in very meaningful ways to implement reform. And I look forward to hearing from our expert panel on how to better foster these connections.
Thank you, Helen. It's clear that we have a lot of work underway and a lot of work to be done. The states are challenged, all states are challenged, but particularly a state like California that's really stepping up and moving forward to implement some significant expansions in our public programs, as well as to stand up a new health benefit exchange, to align state insurance laws with the new federal market rules, to undertake payment and delivery system reforms, and to advance community prevention and population-based health activities. So with the context of these extraordinary, numerous, and let me invite Marian and Andy to come back to the table. But with the numerous and complex implementation tasks as our context, and acknowledging that recognizing information research and analysis represent very powerful and important tools to help inform and strengthen policymaking in our state. We're now going to turn to three leaders in the effort to move implementation forward in California, representing the policymaker, the researcher, and the health foundation perspective. And we've asked each of them to share their observations on really three principal questions. Number one, how do they respond to this issue around information needs and gaps? What are the most pressing policy issues for which research can really help our state be ready for 2014? Secondly, what are some of the constraints or challenges they experience in terms of securing funding or delivering research needs to address those priorities? And finally, how can we do a better job in connecting policy research and information, connecting knowledge with the end users at the program and the policymaking level to strengthen implementation in our state? So we're going to begin with Secretary Dooley, and Diana, take it away. Thank you.
Thanks, Kim. And I want to first really thank and respect the work of the PPIC in really three ways that go to some of the things that have already been said. Making their work accessible is a really key issue, and PPIC is a leader in that. Their work is transparent, it's available, it is not owned by the funder, and everything is published for everyone's use. And so I think it's transparent, timely, and thoughtful, and for that I thank you, Kim, and I think it's a standard that we should look at as we think about how to make the research available, because the issue that was raised before about the funding, what gets funded is often proprietary to the funder. It may or may not be related to the most pressing specific need, and coordinating and cataloging and accessing that information is very difficult, and PPIC is a real leader in making that information available. So I wanted to start there. With regard to the issues that are most pressing questions that we need information about, I don't think there are any surprises. Most of them were included in the summary that Helen led. We need fact-based, evidence-based decision-making is dependent on this kind of information, on how to align better payment incentives. I mean, that's a key issue as we look, and certainly we're looking at that in the difference between fee-for-service and managed care. Managed care is both a way to align incentives, it's also a way to coordinate care. Coordination and integration are key issues as we go forward in trying to reform not only the delivery system, but improve quality and make people responsible for their own care, give them the tools to be responsible for their own care. We have a very complex system with language. We talk a lot about cultural competency and language differences, but I'll tell you, as an English speaker, I often don't understand. I don't understand the insurance forms. I don't understand the medical decisions. I don't understand the choices that I have. And it's very difficult to fight against those systems. An example I often use is mammography. I'm in a perfect category that I shouldn't get an annual mammogram. And it drove me crazy to wait 2 years, which was what the evidence said. But all of the messages that I had about breast cancer made me nervous. And so it's a message to me about how hard it will be to change behaviors and change attitudes, never mind the attitudes of the provider community and the payer community, just the attitudes of the consumer experience and how sheltered our consumers have become by employer-based coverage and premiums supported by someone other than them that started in World War II with price supports, and there was an appreciation of the value, and now the appreciation of the value that's invested by the employers on behalf of employees is lost to a large degree. So we have a lot of macro problems related just to the question of aligning payment incentives. We have geographic differences when it comes to either workforce or adequacy of a network. We've got real dislocations where we've got oversupply in some places and undersupply in others. And that's not easy to shift, and it's not something that research alone is going to help us address. A key issue is the issue of mixed families. We are looking now at what I like to think of as a front office and a back office. My vision of no wrong door and universal coverage is that it won't matter to people what they may be eligible for. They'll go to one place and they'll say, I need health insurance, and once they get there, in the magic of technology, it may be Medi-Cal, it may be Healthy Families, it may be a basic health program. If we do that in California, it may be subsidized care, it may be direct care, but that will all go on by us figuring out how to get them. But for them, it will be simple and transparent. That's a very tall order. We don't have the infrastructure to make that happen as much as we dream about it and want it to happen. State programs coordinating the care between programs. I see that in my current role with many aspects, from prevention at public health to delivery at Medi-Cal to regulation at managed health care to the actual program at Healthy Families, and coordinating the services between two insurance regulators. All of that is complex, and that's just the state's piece, never mind the local government or the relationship with the federal government that is different with the state than it is with local jurisdictions. And then, of course, the safety net and the evolution of the safety net as we bring more people into more traditional concepts of coverage, including Medi-Cal. Those that are left behind are more naked, if you will. There is less political support, for example, for the undocumented, who are going to be left out of this system by virtue of the Affordable Care Act. How are we going to address that? What are we going to do about that? And the cost shifting that we've all regretted and complained about in some ways is, in a quiet way, addressing that issue that we need to address in a more straightforward way. So each of us has 5 minutes. I don't want to take more than my time, but this is just a handful of issues that are significant. They have policy and they relate to the need for data and evidence. But the three challenges I see to actually using that data, never mind collecting the research, but actually using it as a policy maker, is that it's very often very academic. And it's very hard to bring some of this research to a practical level to implement and rely on first. The second is the press of our immediate needs. We're moving so quickly that by the time we figured out what the data was that we needed, we have already had to make a decision, or a decision got made for us. So to go back just to access the data and the research that's already been done is a timing challenge, much less to ask for research that hasn't even been started yet. As we are moving so quickly as we go forward. And the third challenge that I experience a lot is the lip service that too many people give to evidence-based decision making. Very often, they've already got their mind made up, and they only use the evidence that supports whatever they already believed. And so there is that notion that everyone is entitled to their own opinion, but they're not entitled to their own facts. But we don't always behave in that way, and there are so much data available that almost anybody can find facts to support the opinion that they already came to the conversation about. So those are some of the key issues, and those are some of the key challenges that I see as we move forward to implement healthcare reform in California.
Terrific. Thank you, Diana. Andy.
Well, thank you very much. It's a real pleasure to be part of this panel today, and like the Secretary, I'd like to commend PPIC for pulling this together and helping us really think about not just the research that should be done, but sort of the relationship and the process, how it should fit together. Because I think in some ways, that is the biggest challenge historically that health services research and health policymakers have had together, is sort of how to bring their worlds into an alignment in a way that they can benefit from one another. So I think this is an incredibly important topic, and one that unfortunately doesn't get as much attention as it should, but I think is extremely timely given the size of the challenge ahead of us with implementation of the Affordable Care Act. So I'm going to comment on a few things. I want to first say that I am, I guess, the designated health services researcher sitting up here today. Yes, and a lot of people say, like, health services research, it sounds like a research thing. What's the basis of it? And health services research actually is a field that borrows tremendously from other social science fields and brings various tools into play, economics, political science, epidemiology, a variety of different kinds of skills are brought to bear. I think when I think about the Affordable Care Act and implementation, I'm borrowing in this case from the National Weather Service, because I think the big thing that's coming is a gigantic storm that's about to hit our shores in California and frankly going to hit a number of other states. And I think as I conceptualize what do we need to do as researchers to understand the scale and the magnitude and the impact of this, it is a lot like what one would do, I think, if you were sitting inside the National Weather Service and trying to prepare for a very large storm that was coming. And you know, some of the issues, I think in some ways we have a learning opportunity that's already begun to develop in the field of health services research. The state of Massachusetts has in fact gone through and has experienced some of the aspects of what our state and many other states will experience as they move toward implementing this. And there is in fact an emerging knowledge base from that can be drawn from and pulled from. And when I saw Kim's question in anticipation of this, I started to look at that literature and try to think about what are the ways to prioritize the enormous number of questions that one could get into. You know, if you recall during the time of the debate around the Affordable Care Act, we had members of Congress sticking these huge stacks of paper on their desk to sort of, you know, illustrate how complicated and big this thing is. And in fact, there are many, many laws sort of packed into one law in this. And in fact, we could sit around for hours and talk about specific research tied to any one of literally hundreds of provisions that are written into that law. And so I think one of our first challenges is to figure out what do we prioritize? What are the most important things that we need to know first? Just like in the case of if a storm were to hit us, what are the first things that we're looking around and trying to figure out? And to me, those are things like, how big is it? You know, in the same way when we talk about a hurricane, everyone wants to know, is it a magnitude 3, 4, 5? And that has impact for the size of the devastation it will have. So we want to know how many people get covered.
I use a different word.
Well, but I think it's an impact, right? I mean, and so what is in fact the size of this impact in Medicaid, in the exchange, how it affects people in employer-based coverage and so forth? Because in fact, this is a real opportunity, and we want to see, do we in fact capitalize on that opportunity in the way that was anticipated in some ways? So who is affected? What demographic subgroups, what income groups, regionally across the state, people with, depending on what their previous insurance coverage was, those who were uninsured, those who had coverage, because these lives can have both expected and unexpected effects in terms of how this law will impact them. And I think it's a very important question around who is potentially eligible and who is ultimately enrolled, because there's a real potential disconnect if we don't get this right while we're making our home movie. We want to see that, do we in fact maximize the opportunity of the benefit that is available in implementing this law. So I think those are huge, high-level issues that need to be thought about. Secondly, we want to look at what's the impact on medical resources? How are medical resources like primary care providers, emergency departments, hospitals, all our basic services, how are they impacted? Do they participate in ways that we need them to participate so that we can turn the concept of coverage expansion into access expansion. It's obviously not going to be the benefit that we hope it will be if it ends up being a coverage without, in fact, an ability to get in, to see a doctor, and to try to make the use of services more efficient and effective for the people that we're targeting with this law. And so we're going to want to look at what are wait times for primary care providers. What happens in our emergency departments? Do they, in fact, become less crowded because now people have alternatives to go for primary care? Or does this, in fact, become a place that becomes more crowded because of our inability to create a workforce available to provide primary care for those who gain coverage? We do know that when we give individuals coverage who were previously uninsured, that the demand for service is expected to rise. Many people who are uninsured do get care, but they have unmet health care needs that are likely to now be attended to when they gain coverage. While we don't know for certain what the size of that impact is, it has been estimated from previous work to be probably about a 60 to 70% increase in utilization. Well, that will create demands on our healthcare delivery system, and we need to be preparing our healthcare delivery system for that and evaluating how effectively it responds to prepare for that increased demand. Again, if you look at places like Massachusetts, there's actually very encouraging news there in terms of the degree to which primary care was able to be ready and absorb this patient need and to be able to, in fact, see ultimately reductions in emergency department use and increased use in primary care offices. And then I think there's an important set of issues related to, in the same way that if we were monitoring from the National Weather Service, sort of who's in fact paying for the cleanup. In this case, it's who's paying for, in fact, expanding the coverage. We do know the federal government is putting an enormous investment into expanding coverage. Particularly in the first few years, it's fully paying for the expansion of the Medicaid coverage. But there are very reasonable questions to be asked about what ends up being the state share, what ends up being local government share to be able to expand the coverage as anticipated under the Affordable Care Act. And I think careful understanding of this is an important way of coordinating entities in California at the state and local government that have always been and will continue to be key partners in being able to provide access to care for those who will gain coverage. There are really important fundamental questions then about access, cost, and quality regarding the populations who are to be served by this law. Do things get better for the uninsured? If this law is to be seen as a success, we have to expect that things should get better in terms of access to care and quality of care for those who are currently uninsured. And we want to also see, as someone referred to it as, are there any untoward effects? Do those who have coverage today have a better, same, or worse experience as well? Because fundamentally, we're trying to, in fact, maintain and improve care for everyone, and we are hopeful that through this expansion, that is what will ultimately happen. But the only way we'll know that for certain is if we, in fact, go out and try to study that. There are so many different levels of being able to drill down into specific aspects of this law that others have touched on and that we could get into through the questions and answer period and so forth. I think these are incredibly important questions, but as a first step, I do think it's really important for us to prioritize those issues. I want to turn in my last couple of minutes here just to talk about a couple of the other issues that Kim got into, which are what are some of the challenges we would have to be able to take on these priority issues. And I think there's challenges at least a couple of levels. First of all, there are significant data challenges. And this is, in fact, something that I think really differs between the National Weather Service and Health Services Research. And that is the National Weather Service, they got satellites flying around, and they've got sort of what I would call the equivalent of video cameras kind of monitoring things all the time. And so that if something changes, there's a real capacity to notice that and to do surveillance in the environment. Much of Health Services Research has grown up more in what I guess I would call the Hollywood build a stage, a studio stage to take that perfect picture or to make that one episode. And we need to develop more capacity for ongoing surveillance because We are just at the front end of what is likely to be a series of changes over time and implementation, and so that we want to have more capacity to draw on that. Now, we are very fortunate in the state that we have the beginnings of some of these. We, for example, have, through an investment of the state with University of California, Los Angeles, the CHIS survey, which does a tremendous job of monitoring experiences of our population about their access to care and some of their experiences with care. That's a tremendous tool that gives us an ability to monitor some changes over the time. We've also have developed some interesting work with some of the licensing boards in the state. Our group at UCSF, for example, has developed surveys in conjunction with the Medical Licensing Board to monitor participation of physicians and other health professionals in the Medicaid program and other kinds of insurance vehicles that can also give us insights into some of the things that are going on over time. But I do think that we really need to attend to what is our backbone of data infrastructure, what is our satellite equivalent to help us have video cameras to monitor over time as different kinds of changes are implemented. There's another very significant challenge too from the research side, which I think is often not completely thought about because everyone sort of thinks about, oh, we're implementing a change, we'll just want to see how were we before and how are we afterwards? And of course, that's a critical part of evaluating in research whether a policy made a difference or not. But it's probably not quite enough. It's also critical for us to think about what's the comparison group. Maybe some of these things would have changed on their own anyway in some cases. And while that sometimes feels like, is that really possible that we would have gotten this many people insured or into care and so forth? It is really helpful to understand and to identify the impact of a policy if we can find a reasonable comparison group. And I do think we're going to need to employ researchers to really think about what is the right control group, in a sense, to compare what has gone on here. Maybe it's those who had insurance throughout. Maybe it's going to be the benefit of some states that decide to slowly get to implementation, and we're going to be able to make comparisons with those states that are slower to get on board with implementation than California is likely to be. I would just raise this because I think it's an important part of a strong design to really help us know at the end of the day whether our policies are making the kind of differences that we're hoping to make. I want to touch on just a couple of other things, and then I'll turn it over to Marion. But I think there are also some very significant challenges for the research community in terms of how do we get this all paid for? And I think that's a big part of what we're here to talk about today. We're extremely fortunate to have foundations in our state that are in fact invested in a serious way in trying to do good research that is meaningful for policymakers. But you know, it's still a maze of sorts as a researcher to try to navigate through that, in the sense that you know, I sometimes feel a little jealous of my lab-based research colleagues who have a much more organized structure through something like the NIH, where there are clear deadlines of when you can apply, and the strategy of how you go through that process is much more structured and specified in some ways. I'm not saying that we necessarily need to replicate that in the health service community. On the other hand, I do think some coordination could in fact enhance the ability of researchers to work together in a more integrated fashion to make sure that they aren't being redundant with one another, that we aren't missing important gaps of what we should be attending to. Right now, there are some real challenges with different foundations having different timing, different kinds of priorities, sort of different sets of rules in some ways that I think results in some inefficiencies within the research world in terms of how effectively we can design research to work along with policymakers to address the important issues. Finally, I just want to touch on this issue of, you know, working with policymakers and what is it like from the research perspective, and are there pluses or challenges to doing that? I think research with the policymakers is by far the most significant and important opportunity that health services researchers have. I think, in fact, the health service research community is increasingly recognizing that just writing articles that aren't helpful and putting them in journals where they, in fact, only educate one another is not the goal here. We need to find ways to create work that is valuable in a timely way. And I think it's the challenge and a tremendous opportunity for us all. I think there are, the upsides of this are not only to have impact in terms of the work, but also to open up opportunities for access to unique data that would otherwise perhaps not be available to the researcher. I think it does create opportunities for synergy and funding that may not otherwise be there between both state funding and foundation funding, perhaps coming together in a useful way. And this has been absolutely the goal of what the California Medicaid Research Institute has been all about. We are a collaborative of the faculty of the University of California that has formed a master agreement with the Department of Healthcare Services for the explicit purpose of, in fact, trying to better align researchers at the University of California to work on problems identified by the department and to really try to make sure that the solutions and the research that's being attempted really matches with what the needs are at the state. Now, there are still challenges that remain. I mean, there's no question that the timeline and the cultures of state government versus a university faculty are different. But I think that we have now been developing in a very nice way an understanding and trust between the faculty and policymakers that is critical to ultimately make research better align with what policymakers need. So while I think there are still challenges ahead in trying to do this, I think the timing for doing this is critical, and it's a fantastic need, because the opportunities available to us through the ACA are so great that we just don't want to miss this opportunity, and I'm really pleased to be a part of this to talk about ways that we can even promote it further. So thank you very much.
Thank you, Andy.
Well, I want to add my thanks and appreciation for being here today. I want to acknowledge the work that Helen and Kim did on this analysis, which I think is really thorough and excellent. And appreciate Blue Shield of California's funding, as well as acknowledge PPIC's work, not just in the healthcare research world that I'm familiar with primarily, but more broadly on the issues of governance and the timely policy issues of our day that they've really contributed to a lot. As the funder, the token funder on the panel, I do want to acknowledge what you've heard a little bit already about that. There is a very rich diversity of funders in this state and nationally that are engaged on this issue. And while, of course, I can most well reflect the California Healthcare Foundation perspective, I think that we are a resource, and I think considering how we can work together and work with our colleagues in both the research and the public sector is a really important topic. I'm going to organize my remarks as the other speakers have, briefly talking about what the big topics are that would benefit from more research and information, and then talk about a little bit about the challenges and opportunities. On the topics, I thought I think you'll hear a lot of duplication and reinforcement of what you've heard, but I thought I'd organize my remarks from sort of the broadest system-wide impact to sort of the individual consumer impact. And I'll run through these, but I think it is kind of a useful way to think about this, because we all go to various places about what this law will mean and who it will mean it to. But it's important to think about that vantage point, I think, as we go forward. So I start with system-wide costs and the value that people are getting after the health reform law is implemented. So in aggregate, has health reform mitigated or aggravated the pace at which healthcare spending is increasing? So, we know healthcare costs are going up quickly in the aggregate. Will it get better or will it get worse, both in the short term and in the longer term? And of course, as you have that higher spending, what's the benefit that goes along with that? Who's better off? Who is paying more, or whose costs are being reduced? So then from the system to the of healthcare costs to the care delivery system, how are things working in the way that care is delivered? Is there more coordination across the continuum of care? Are there convenient and culturally appropriate care delivery options for people in all kinds of different circumstances? Are there some new lower cost models being developed for delivering health care in new and innovative ways? My third bucket after the system-wide costs and the care delivery system is coverage, and that's maybe the most obvious impact that we all anticipate under this health reform law. Who's got coverage? How does that compare to who had coverage before the law was implemented? But drilling down a little bit from there, what kind of coverage is it? What are its terms and limitations? How much does it cost people? How much do people spend in premiums? How much do they spend at the time of service? Next category is people's access to care and the quality of care that patients and consumers get. So do people get the care and attention they need when they need it? What's the quality of that care? And again, how are those outcomes distributed across the continuum? Are there some people who are benefiting greatly and some not so much? And then finally, linked to all of those categories is this question of consumer experience and satisfaction. And of course, if all those things are true, the healthcare delivery system is working better and people are covered and they have access to care, we would hope that people, consumers, would be happier and better off. But I think we'd be remiss if we didn't specifically ask those questions as well. If we stayed up at those system issues and didn't get to how people are experiencing the changes, then we would have missed something. So to me, those are the big areas that we will need to be watching as this reform law is implemented. And those are areas where there's lots of good work, there are lots of baseline data, but to systematically consider those changes as we go forward, I think will be important. On some of the challenges, we've heard some good ones nominated already, not all of which I've thought about, but I'll start with just, again, sort of stating the obvious, the breadth of demands and the timeline over which this law is being implemented. There is so much going on for all of us, and the balancing act of trying to focus on what's important, sustain enough attention so that you do something meaningful and not miss all the other things that need to be attended to as well is really a significant one. And that's true for somebody like me at a foundation with the relative luxury of being able to set my own agenda. I can only imagine how challenging that is for my colleagues in the public sector who frequently have agendas imposed upon them. So I want to acknowledge that that is a huge challenge that we need to collectively navigate with, I think, sympathy for our colleagues in different circumstances. Maybe that's the wrong one. So that's sort of the complexity. Even if we could understand all the elements of the law and prioritize among it, it's not just that it's complex, it's that we are in a fluid environment. And I probably don't have to say a whole lot more about that on a day when this law is being heard before the court. But the reality is that with any big and complex law, it won't be implemented exactly the way it looks like it will be today. There will be changes, there will be adjustments. The interaction between the federal guidance and the state decisions will be a continuing balancing act, and we'll all need to be responsive and flexible as we try to anticipate those and monitor their impact. I want to, finally, in terms of challenges, I want to acknowledge that there are issues around prioritization and values. That is to say, when you look at all those different things we could be paying attention to, all those different outcomes that we could be considering, different ones of us will probably come down in different places about which are the most important. I may think that consumer impact is the very most important. You may think that the system-wide costs are. Another person at a different moment might think that the delivery system is something that must have attention in a particular moment. Fortunately, again, in California, we have a great wealth of both research expertise, funders, and other actors in this field to look at all those different areas. But I think we need to acknowledge that we may be in a little bit different place at different times. I want to acknowledge Andy's remark about the funding ecosystem and the priority thing. I think it's a really good reminder that while I may feel like I have a pretty good understanding of how my foundation works and what our priorities are and what we fund, we are not always as transparent as we should be. And while we try hard to communicate with our funding colleagues and identify and communicate, there's always opportunity for improvement. And I think that that's something that we can all work on going forward. And that kind of leads me to the sum up of the opportunities that we have before us. This is such an extraordinary time, and it is such a privilege to be working on these issues of health reform implementation and broad coverage expansion and healthcare system improvement, that I think that what we need to guard against is feeling so weighted down by the obligations of monitoring and measuring that we don't acknowledge and advance those good outcomes that we all have the opportunity to work toward. At our foundation, at the California Healthcare Foundation, we tend to look at our work in the implementation and monitoring area in two ways. One is to say, when there are short-term policy questions or research issues where we believe we can make a timely contribution that play to an area where we have the flexibility and the knowledge to contribute, then we try to do that, and we try to do it quickly and effectively and find the right research partners to serve the policy audience that we have identified. But we also feel like we have an obligation and an opportunity to develop a framework and to look long-term and big picture. And when I think about what foundations are best at, I think that there are two characteristics. One, our independence, and two, our ability to take the long-term view, to be able to sustain our attention on certain issues or outcomes that perhaps others don't always have the opportunity to do. And so we feel like we have an obligation to use those resources to track the impact of major policy changes and to try to inform the many decision makers who can make a difference in those outcomes. A couple of opportunities to conclude with, and you've heard it referred to. As we make all these changes, we would really urge and really hope, and we'll be working to try to get transparency baked into some of the decisions that are made. It would be much better to have new systems put in place that automatically report data out rather than to have to come back in 5 years and say, dredge up that data and say, what did happen and how have things changed? And then I think there's just this opportunity to continue to play to our relative strengths across the sectors of decision makers, researchers, funders, and all the other people engaged in this effort, and think systematically about what those strengths are, where it is that we can each contribute and make a difference, and how we can keep the doors open to communicate and coordinate as we do that.
Great, thank you. I want to thank our three panelists for sharing their perspectives on some of the critical information research issues, as well as opportunities to better connect research and policymaking. And we'll have a brief dialogue here before opening it up to all of you. And I want to go back, Diana, to one of your opening, or one of your comments about the challenges. We heard a lot about the challenges associated with developing and connecting policy research to the end users in terms of policymakers, program administrators, et cetera. We heard about the timeliness issues, data limitations, financing, some of the issues working with policymakers. You noted kind of the academic orientation of work that is produced. Do you have some thoughts on how the research community could do a better job in terms of being responsive to what you need as a policymaker in terms of products that are packaged and produced in a way that's digestible and answering the questions you have and responsive to your timelines?
I actually think that we have different roles in the process, and I didn't mean to imply that it was a criticism. I think academics have the space that Marion just referred to see the long view and to look at issues more broadly. It's our responsibility to take that information and apply it in a practical way. I just meant to suggest that they aren't directly related, so that picking through the academic issues, and it's frustrating sometimes for policymakers, and I see this particularly in the legislature at hearings where they want an answer. What should we do? What should we do is the question that someone responsible for doing it always has. What do we do first? What do we do second? And you're not going to find that as a conclusion in an academic paper. For the very values that Marion emphasized, the academics, and I don't mean that pejoratively, stay away from the actual application of the information. I think more importantly is distilling that information in a way that's practical, that we can use and that we have access to go back and ask for clarification. And an example that Peter alluded to in his remarks is the work that Ken Jacobs presented at the Health Benefit Exchange meeting last week about the uptake and who can we expect to be remaining in the end insured, and what are they going to look like, what are those people going to look like. And he came to us with that in a preliminary view in February, and we looked at it and we asked questions about it, and then he went back and he answered those questions and presented it in a very thoughtful way. So I think that's an example of the way we can work together with academics, but we aren't going to be the same. We don't do the same things.
No, I think that's absolutely right. Marion, as a funder, it's interesting in the scan we did talking to dozens of researchers, funders, policymakers. One of the themes from researchers was that one of the challenges they face is around this issue of dissemination and formatting and product, and a recognition that, as a state, as we heard from our panelists, we have an abundance of super smarty pants, as I call them, really, really capable researchers and research institutions and collaboratives. So we are enormously fortunate in that respect. But you hear from researchers this challenge. We struggle with how to connect the work we do with the research or the policy community that needs it. What are some of the lessons you've learned from a foundation perspective? And indeed, people say, we look to the foundations to help us. So what are some of the lessons you've learned in terms of connecting policy research with policy makers? And do those strategies vary based upon legislature versus executive branch versus intermediaries that endeavor to influence the two?
Wow. It's one of those multi-part smarty pants questions. We have learned a lot, and yet there continues to be so much to learn, I guess, is what I would say. Certainly trying to really get to understand our audience and the environment that they're working in and the decisions that they are trying to make, so that both the structure of the research and the way that findings are communicated is focused and germane to what they need is part of what we do. At CHCF, we spend a ton of time on the publications that we do, honestly, more time than we probably should, too, in terms of being timely, to get high-quality publications. And we think that those, in some cases, can be very useful, especially for long-term issues that have some shelf life. But increasingly, we're learning, too, that sometimes there isn't time to do the perfect 8-page issue brief. Far more important to get the researcher in front of the exchange board, or to do a briefing like this and have the conversation and let members of the audience ask questions, so that real time you can grapple with some of these issues rather than try to do the perfect 8-page brief with some recommendations that by the time it gets out maybe aren't quite to the point that you're looking at. So that's my high-level thoughts. With respect to legislature versus administration, certainly an acknowledgement of the different jobs that they have to do, as the Secretary suggested. There's the implementing and action steps versus the lawmaking and perhaps oversight steps. And I think, the advantage of working with the administration is it is a little bit more one-person kind of an undertaking rather than the dynamic of the legislative process itself.
And I would just add to that, Kim, that we never are going to be able to implement anything in a pure academic way. And so we can only be informed by the academic papers, and the extent to which people who have done them are frustrated by our not being able to follow their precise prescription, interferes a little bit as well. I mean, if people can just see that we heard them, that we listened to them, and that we were informed by their data and their conclusions, even when we can't follow their prescription, that is important. I think we have to respect the different roles that we play in this process.
And you touched on the California Medicaid Research Institute, Camry, which is actually a really exciting and innovative collaborative model that endeavors to bring together in a very purposeful, thoughtful, and strategic way the executive branch on the one hand and a number of researchers from within the UC system. It has the benefit, the happy virtue of having federal funding, and there's nothing like dollars to really galvanize attention and focus. But it also is important in terms of UC actually has staff within the Department of Healthcare Services. So it's not just a research development effort, it's actually a capacity building effort within the department. Are there some lessons associated with CAMRI that could be extended beyond Medicaid? Because as you noted, CAMRI is specifically related to Medi-Cal, and yet Medi-Cal, while it is the mothership of health and health reform, is one piece of a larger series of issues. So what are some of the lessons learned for reform more broadly?
Yeah, well, thank you for bringing up, I think, the important issues. In CAMRI, we've really tried to tackle directly kind of the infrastructure and the basis of how, in fact, researchers could come in better alignment with policymakers. And one of the things I liked about how you set up your question, Kim, is that we really have viewed this as a participatory model. And what this really means is not just thinking of course, policymakers get the questions from the legislators or from from the governor, wherever, but it's also an opportunity, I think, to exchange in a bi-directional way between the kinds of questions that investigators may bring up as well as what policymakers may bring up, and jointly to choose what are the research questions that are the most relevant. Similarly, how are the methods employed in a way that both sides see benefit and make sense in terms of what are some of the opportunities of the data, but also some of the limitations of approaching questions in particular kind of ways. And the real downstream benefit, I think, of sharing from the very beginning, of choosing and participating together in selecting the question, is preparing the soil, if you will, for when the answer comes back. People aren't, I think what happens so often is researchers show up and say, I've got the answer for you, and someone's like, we didn't have a question, and it just doesn't work. And so on the other hand, if in fact the question was jointly chosen, and in fact there's an updating and a process along the way, and we do have staff that are based, our key person here in the audience today, Kathy Hoffman, is the Deputy Director of CAMRI, and she spends pretty much half of her week every week based within the department, as well as then back at the University of California, and really is a critical sort of knowledge broker going back and forth between investigators and the policymakers and understanding those two cultures. But by preparing the soil and picking the question together and updating along the way, then there's an opportunity to really engage in the findings in a different kind of way. And it isn't like there's just a beginning and an end. Gee, we started the research, we got an answer, now come on, why aren't you implementing? It's not like that. It's seen as much more of an ongoing, continuous process. And more directly to your question, Kim, absolutely, we started this process with the Medi-Cal program as the mothership. It actually preceded what we necessarily knew would be the case with the Affordable Care Act. I see Sandra Shuri is here today, and Kim, when you were the secretary, was really when we formulated this idea and placed it within the Department of Healthcare Services. But as the world is evolving with the development of the exchange and what's happening with the Healthy Families program and so forth, I think thinking more broadly about how to bring a closer alignment between researchers and policymakers beyond just Medi-Cal is a really important model. And I think a key thing that is so hard for many times the researchers to do if they're left to do it individually is to create enough face time, if you will, to keep the dialogue going. I had the good fortune of spending some time in Washington during the time that the Affordable Care Act was being turned into law, and what I realized is that airspace of communicating regularly with policymakers is sometimes really dominated by groups with very special interests. And I think what's really a nice thing to think about is how do we get that airspace between policymakers filled more with the opportunity for objective researchers who can be true partners with policymakers to help develop the information that will allow decision-making to feel at least a bit more organized. And so that it isn't just, here's the latest study, please implement that, but an ability to systematically bring together the body of evidence and to weigh the pluses and minuses of what it says, and recognize at the end of the day, yes, policymakers have to hit the stop or start button and so forth. So yes, absolutely, I would think that the Camry model is one that could be expanded, and I would hope there's, and I know there's a need for it at the Exchange and other places, to really think about how to leverage the tremendous resources of the University of California to work in closer alignment with policymakers.
And one of the findings that Helen and I took away from our SCAN project was in our conversations with our executive branch colleagues, we were struck by the theme of, as articulated by staff, that within our various departments, we do have a wealth, an abundance of data, an abundance of information. But there was some questions about, struggling with, well, what do we do with it? Do we really understand how to use it to frame a question and to inform more evidence-based decision-making? And I think, as you know, one of the benefits of Camry has been to have actual staff co-located within the department to help build that capacity to collect, to understand, and use department data. Let us now turn it over to you and see if people have some comments or questions for our group of panelists.